Hello, I'm Georgia Tobiano. I'm a joint appointment between Griffith University and Gold Coast Health. Today I'm presenting on older patients' engagement in medication communication. Our wonderful team consists of Professor Wendy Shaboya from Griffith University, Gemma and Trudy, pharmacists at Gold Coast Health, and Professor Elizabeth Manius from Deakin University. In this study, we were exploring medication safety behaviours in hospital. Our aims were both to describe and identify relationships between older patients' preferences versus their behaviours, as well as to compare whether medication safety behaviours differed between different age groups of older patients, including young old, middle old, and old age groups. This study was a cross-sectional survey design. It was conducted at one hospital across 6 medical wards. We used the inpatient medication safety involvement scale for our survey, and this consists of 6 medication safety behaviours, including patients looking at their medication chart, asking questions about medicines, keeping and administering medicines, and checking with a healthcare professional if they thought medicines were forgotten or wrong. For analysis, we did descriptive statistics and tests specific to our aims. 200 patients completed the survey. The median age was 74 years. Around 60% were men, and patients were prescribed a median of 12 medications on discharge. In the graph on this slide, we have provided the percentage of patients who responded with agree on survey items. The red bars represent questions about patients' preferences for medication safety behaviours, while the grey bars represent patients' reported medication safety behaviours. That is, if they think they have done the behaviour while in hospital. Before we start, it is important to tell you that the questions about checking if medications are forgotten or checking if medications are wrong only had preference questions on the survey. Patients weren't asked if they think they did this behaviour, so that's why both are 0 for the grey bars. Starting at the left side of the graph, you can see that patients wanted to enact verbal medication safety behaviours, like asking questions and checking up on medications that were wrong or forgotten. In fact, around 60 to 85% of patients wanted to do this. More physical behaviours like self-administering medicines and looking at medication charts were not preferred, with closer to 20% of patients wanting to do this. Spearman's row was used to see if there were significant differences between patients' preferences and their reported behaviours. We found a median positive correlation, meaning patients thought they were enacting their preferred behaviours in hospital. And you can see this in the graph. For asking questions, around 60% of patients wanted to do this, and around 60% of patients thought they had done this. Finally, we did a Kruskal-Wallis test to compare the difference in age groups. We found a significant difference only for one question, which was, I would check with a healthcare professional if I thought I might be given the wrong medication. The young old group, aged 65 to 74 years, were much more comfortable to speak up about this to ensure their own safety. It's really great that we found that patients are comfortable with verbal medication safety behaviours. In fact, around 60 to 80% want to ask questions or speak up about their medicines. So this is really great news for choosing wisely medication conversations. But there's still room for encouragement from healthcare professionals, as this means around still 40% of patients did not want to or did not ask questions about their medicines. Also, we found that the young old group were more comfortable having conversations about medicines that were forgotten or wrong, important safety issues. So it may be that different strategies are required for the middle old and older patient groups to make them feel more comfortable talking about their medicines in hospital. These groups have unique factors. They often don't want to be seen as confrontational and may rely on families to be present during medication conversations. So it's really important that we consider individualised strategies for these groups. Overall, the willingness of patients to engage in verbal medication safety behaviours was really promising, and healthcare professionals and organisations need to be ready to accept and embrace this willingness.
Thank you for giving me this wonderful opportunity. My name is Rajni and I'm a periop geriatrician with interest in shared decision making and frailty. So where it all begin? Well, let's wind back the clock during pre-COVID times, year 2019. And I was in London doing my fellowship in periop medicine of older people undergoing surgery, in short, POPs. And during that time, a great opportunity came to me whilst listening to geriatricians talking and discussing about shared decision making and a famous Montgomery case. Now, for those who are not aware, it's about a pregnant woman with gestational diabetes, short stature, and a large baby who delivered her son vaginally, leading to shoulder dystocia and hypoxic brain injury and cerebral palsy. These are known risks for patients of her caliber, but unfortunately, the patient was not informed of these risks or alternatives, and she sued her obstetrician, and Supreme Court found that in her favor. And this started a huge discussion in our department about shared decision making, in short SDM, and most geriatricians were certain that SDM was being performed and documented in their clinical letters. And I volunteered to review this in our clinic, my primary objective being to review if it's being documented, and secondly was the shared decision making satisfaction for both patient and clinician. So today I will discuss what shared decision making is, a bit about my project and what we can do in Australia to become leaders in SDM. But before we start, let's make sure we have a mutual understanding of what we're talking about here. SDM is a collaborative process where patients and clinicians work in partnership to reach a treatment decision based on clinicians' expert knowledge and patients' preferences and values. Clinician discussing the risk and benefits of all available options, ranging from the most invasive to the best supportive care, and making sure that they take a health literacy into account. So in a nutshell, SDM places a patient at the heart of decision making, and increasingly we know that patients want to be involved in making decisions about their own healthcare, and research has shown that when they do so, they select less hospital care and report better hospital experiences. And some of the other benefits of SDM is that it encourages patients to actively participate, but also improves communication, which reduces decision conflict. And we also know that informed and involved patients demand less and not more. Now, these concepts are not new to any of you here. In fact, I'm aware that I am preaching to the converted. SDM resonates consistently with the goals and the 6 core principles of Choosing Wisely Australia, and that's why I desire to work together alongside Choosing Wisely Australia to assist in my journey. I've already outlined the objectives, and this was a quality improvement project that took place in 5 stages. And during these stages, various interventions took place. Initial clinician interviews and reviewing clinical letters identified that SDM was performed in clinic, but documented at ad hoc basis. So we needed a simple tool for documentation, and based on literature search and reviewing resources, UK ToolAid seemed most appropriate, but because it included the benefits, the risk, alternatives, and nothing, and a mnemonic simply put as the brand tool. And this can be used in any area of medicine, including discussions about tests, procedures, or treatment. I'm aware that Choosing Wisely Australia encourages 5 questions to ask, and now these are great questions and mirrors the principles of SDM, though often in a very busy, stressful clinical setting can be forgotten. UK has utilised the same questions, only simplified it so a clinician can recall the brand tool when they're having a difficult discussion regarding treatment options in their clinic. So after incorporating brand tool, what we found was that only 59% fully completed all components of brand. And this was a worry. We needed additional interventions. And after that, we improved it to 98% and it reordered after 4 months. It remained consistent. What you can see here is that brand tool throughout the time showed high patient and clinical satisfaction, but without workshops and education, completion rate of brand tool components are low. Therefore, it is important to incorporate additional education resources. So, and final, this quip is the first of its type. I would say I encourage all of us to discuss and document concepts of SDM. And on a personal level, I've gained research skills and hope to work with Choosing Wisely Australia. And as a nation in Australia, I hope we can be masters in SDM. And remember, SDM is everyone's business. Thank you.
Hello, and thank you for the opportunity to present today. The Women's and Children's Hospital in Adelaide, South Australia is a quaternary hospital providing paediatric, youth and maternity services. Our Choosing Wisely journey started in earnest in 2019, and we started by introducing our staff and consumers to the concept of choosing wisely. During this socialisation phase, our consumers provided the feedback that they loved the concept, but the images didn't grab their attention. It just didn't look like it was for us. So we went back and thought about our demographic. In our women's and babies services, the average age of our adult consumers is 28 years, and in the paediatric services, the average age is 7 years, with 20% of admitted paediatric consumers aged between 15 and 18 years. So our consumers are predominantly a young group. We needed a more youth-focused image. We consulted broadly through our established consumer pathways, including groups with all age ranges represented from under 13 years to adults, as well as parents and carers. We used our online consumer feedback portal and our consumer committees. We also sought input from the health literacy, consumer engagement, communication and digital media teams in the hospital, as well as a number of convenient samples of staff. The result was a bright, colourful design that retained the Choosing Wisely Australia wording of 5 questions, but with eye-catching imagery that was appealing to youth. We displayed this on our TV screens and posters throughout the hospital. During the design phase, there was feedback from both consumers and staff about the value of the Choosing Wisely Australia wallet cards as a resource to take away with you. So we included a resource card in portrait mode. Now we had a great suite of resources that caught our consumers' attention, and we wanted to know if the introduction of structured questions was useful for youth. The adolescent ward commenced a project to evaluate introducing adolescents to the 5 questions to ask resource card. The plan was for all young people to be provided with the 5-question resource card on admission by the nursing staff who are ready to answer any questions. Our posters were displayed prominently on the ward, with smaller versions included in the admission information. Evaluation was to be by an anonymous survey completed by the young person on iPads, supported and facilitated by our play leaders, ward clerk and volunteers. Unfortunately, COVID restrictions affected our plan significantly. Staff education was severely limited, iPads were sequestered for consumer communication, volunteers were not on site, and staff who could work from home were instructed to do so. Our start time was delayed as we developed alternative survey collection methods, including a QR code and paper-based surveys. However, the most successful was a personalised approach in which a team member simply asked young people to complete the survey. We felt that there were 2 key contributing factors to our relatively low resource response rate: the COVID restrictions and the timing of the information. There's a lot to think about on admission. However, the results that we did get were positive. 60% of our respondents were aged 16 years or older, so they're old enough to provide their own medical consent in South Australia. 65% had not previously used structured questions to help decision-making with their healthcare. 66% thought the questions would be useful to help decide on their healthcare. 79% thought we should continue to provide the card on admission, and 64% already had or had planned to look at the Choosing Wisely website for further information. Some of the comments we received were, "It's helpful to see what I need to ask. It reminds me that you can ask questions. It will help me find out what I need to get the best health. And it's helpful for those that may be overwhelmed and not know what to say or ask." So our consumers had told us that we needed a youth-focused image for Choosing Wisely, and our custom-designed resources meets this need. Young people told us that the information is helpful and that we should continue to give out the resource card. But we do need to think about the timing the information's provided. And some of the ideas that we're currently exploring are perhaps to print the information on a placemat for young people to read during meals in the hospital, to include the information during their transition to adult care appointments, to think about including it in chronic disease education by our specialist nurses, and perhaps through the hospital school, or should this be taught to all children through education? A resource designed for young people supports shared decision-making, and our goal is to provide this in an effective way. We believe we're at the beginning of a journey to better support young people to be active participants in their healthcare. Thank you.
Hi, I'm Tom, and I'd like to talk to you about our brand new synthesis of qualitative research about lay understandings of overtesting and overdiagnosis. In this synthesis, we included research from anywhere, anytime, and about any condition, as long as it was in English. Out of almost 3,500 studies screened, we ended up synthesizing 21. Their analysis comprised two layers. Firstly, a descriptive synthesis, which systematized overt ideas in the data. Then secondly, an analytic synthesis, which examined underpinning latent ideas behind the descriptive themes. Most of the studies in the synthesis came from Australia or America, and all came from high-income countries. They focused on women, cancers, and used descriptive analytic designs. I think the 21 studies we synthesized represent a body of really great, important, and high-quality work. But I also think the things I just mentioned all point to gaps in knowledge. The main limitation of our synthesis was that we couldn't differentiate between overtesting and overdiagnosis in the data. People appeared to often muddle the concepts, or it was unclear which they were discussing or thinking about. And that was the case even in studies that focused on just one concept. I think that actually represents an important finding about how people understand these concepts, but it meant that we had to report on an amalgam of these concepts in the results of the synthesis. We identified 6 descriptive themes. People had a lot of confidence in screening and testing. They found messages about overdiagnosis and overtesting really tough to make sense of, although they did generally accept that overtesting and overdiagnosis can cause harms. At the same time, they often rejected or problematized these messages about overtesting and overdiagnosis, and the messages appeared to have pretty limited impacts on the extent to which people wanted to take up tests or screening. It was very common, however, for people to want more information about them and to want to share decision-making about overtesting and overdiagnosis. We believe that the descriptive themes are underpinned by 2 underlying ideas. Firstly, people appeared to believe that information is inherently valuable, and I think this could be seen in the data about testing, where tests were considered objective information gathering devices, ones that enable medical decision-making, not that require it. You get the test and then you decide what to do. So the idea that you need to think about whether to get the test or that the test can hurt you was really tough for people. We believe the same belief in the value of information accounts for a desire for overdiagnosis information. Because even when people didn't think that overdiagnosis or overtesting were particularly valuable concepts, they wanted to be told about them. And I think that reflects this idea that you get the information, then you decide what to do with it. throughout the data, it appeared that people had a lot of confidence in their ability to use information effectively. We also think that the descriptive themes are underpinned by distinct understandings of overtesting and overdiagnosis concepts. People appear to understand these partially and accept them partially, and importantly, they appear to reinterpret them through the lenses of their own beliefs, values, and experiences. And for example, the causality between too much testing, overdiagnosis, and overtreatment didn't resonate so well with people because it appeared that many believed that as long as they understood these concepts, they could continue testing as normal while avoiding overtreatment. The synthesis is important because it will allow us to shift approaches to communicating about too much medicine to people. It showed that promoting an accurate understanding of these concepts may be really difficult in public health campaigns, but actually I think we only need people to have limited accuracy of understandings. I think what we actually need is to work with people to understand their beliefs, expectations, values, experiences, and develop messages that respond to all these things that will help shift how the public think about their healthcare interactions. And I think communicating specific concepts is an important part of that, but we may overestimate its importance or the extent to which accuracy is required. I also think it's important that in developing messages, we make sure they don't have any unintended consequences. I think the choosing wisely questions are actually a good example of a tool that communicates a mentality, and our synthesis highlights the potential value of such tools. The synthesis also showed that we need to be cautious about interpreting public's desire for more information about overtesting and overdiagnosis to mean that the people want to be involved in reducing it. Fundamentally, people often just want information. And finally, it showed that patient-centered reductions to overtesting might be a tough task because overtesting was such a counterintuitive idea. That's all the time I have. But if you'd like to know more, please do get in touch. Thank you very much.
Hi everyone, I'll be presenting findings of a qualitative study exploring community views on a public health campaign. Unnecessary imaging for low back pain is common. For example, 1 in 4 patients with low back pain presenting to primary care received imaging. This is problematic because it places a patient at risk of overdiagnosis. Overdiagnosis happens when a person receives a diagnosis that causes more harm than good. It ends up increasing worry but does not improve outcomes. We developed a campaign along with advertisers to communicate this problem of overdiagnosis to the community. The aim of this research was to evaluate community responses to the campaign. We conducted focus groups with community members. We did thematic analysis. Campaigns included 5 posters and a leaflet about overdiagnosis. And this is what our leaflet posters looked like. They used strong imagery and language to emphasize on harms of imaging. Each poster incorporated the slogan, "Scan your options, not your back." The posters were designed to be displayed on a 55-inch digital screen in the waiting room of a hospital emergency department. The information leaflet had 2 pages with 6 panels of information. Each page contained cues to emphasize the potential harms of unnecessary imaging for low back pain. It also gave a list of things to do instead of imaging. We developed the materials to be suitable for people with an average reading level of grade 7. Majority of the participants in our study were female. They were born in Australia, had low back pain in last 12 months, and had undergone imaging before. Now moving on to response to public health campaign. Participants found messages to be surprising and alarming. They had mixed feelings about using fear to promote health. Some participants felt the posters were designed to generate fears among public. They linked the approach to public health campaigns for smoking. For example, a participant said, "You know what it reminds me of? Smoking kills." And another participant said, "At least it's true, smoking kills, and there's been so much research." Participants had mistrust of veracity, source, and intent of information. Participants looked at campaign with skepticism. They expressed disbeliefs at the messages. For example, in response to a poster with a renowned orthopedic surgeon, a participant said, "He's classified as an orthopedic surgeon. So is he practicing? Is he retired? Where does he sit in that field?" And another participant said, "That's one doctor I wouldn't go to because basically he's saying most people won't benefit from having a scan." Messages seem to conflict with the pre-existing beliefs about the value of imaging. Some participants reacted negatively to the concept of a health service wanting to reduce imaging. Finally, some participants found messages to be useful and informative. Some participants appeared to understand the reasons why imaging is not recommended. Participants were positive about actions to take and imaging alternatives. For example, a participant said, "Advice on actions to take at home is all you need, nothing else." For some participants, the campaign materials encouraged them to think carefully and not rush into a decision. Participants appeared to gain a better understanding to the concept of overdiagnosis and the importance of not simply rushing straight to imaging. A participant said, "Like if you get the flu, you get a backache. You don't want to rush down and get a scan." Our findings suggest that interventions using strong imagery and messaging could help raise awareness about the harms of overdiagnosis, but could also generate negative reactions, including mistrust among community members. Therefore, future research could investigate the relationship between source of information and trust, fear appeals versus positive appeals, such as use of humor or actions to take, and role of clinicians. Thank you.